So for tonight, what we have is we did something special for tonight, and this is the fourth program in a four-part series. Tonight, we're speaking about bowel and bladder issues. And if you don't know me, just know that my name is Stuart. And Dr. Ben Thrower, we recorded this program in advance. But I want to let you know that Dr. Ben Thrower is the medical director of the Andrew C. Carlos Multiple Sclerosis Center in Atlanta, Georgia. I have come to know that term very well over the last few months, and I don't even need to look at paper while I'm saying it anymore, so that's pretty cool. But so again, we video recorded these programs, and then Dr. Thrower comes on after the program. The recording ends, he will come online, and we will do Q&A for this topic. We're sponsored by Bristol Myers Squibb, TG Therapeutics, and Novartis. I want to thank them greatly for sponsoring and supporting this series that we did. And so we look forward to doing something again with them next year, similar topics, but let's see where this one goes. Let's take it away, Doctor. Well, it's not for you, Doctor. It's my AV person. Let's get the recording started, and then we'll be back on in a short while. Thank you.
Good evening, and thank you for joining us. My name is Ben Thrower. I am a neurologist. I'm the medical director of the Andrew C. Carlos MS Institute at Shepherd Center in Atlanta, Georgia. We're taking an interesting look behind the scenes at comprehensive MS centers. I think this is a unique program, and it kind of pulls the curtain back, if you will, on what goes on and what you might expect if you're going to a comprehensive MS center. MS is complicated. It varies tremendously from person to person. There are a lot of different healthcare providers involved in MS care, ranging from the neurologist, the physical therapist, occupational therapist, psychologist, just so many different providers. And at a comprehensive MS center, we have the opportunity to hopefully put all of those pieces together in not only a comprehensive way, but in an integrated way, so that those pieces of the puzzle are communicating and playing well with each other, ultimately to the benefit of the person with MS. One of the things that people with MS deal with that can be very frustrating and affect quality of life would be bowel and bladder issues. It can be a little bit embarrassing to talk about these things. Sometimes people with MS are reluctant to bring that up with their healthcare team. Sometimes healthcare providers won't bring it up unless you do. So if you are dealing with bowel or bladder issues, make sure that you discuss that with your healthcare team. So let's talk a little bit about bladder first. So bladder issues probably affect 65, maybe 70% of people with multiple sclerosis. And there are several different things the bladder can do in multiple sclerosis that might affect you. So the most common thing we see is a small overactive bladder. The bladder fills up a little bit, it wants to go right now. Strong sense of urgency. Maybe you don't make it to the restroom on time. Maybe people have accidents with this. Well, people will describe feeling like there's gotta be a gallon of urine in there when I go, and when they get there, there's a very small amount. And the question is, well, really, I had all of that for this small amount? Unfortunately, then this cycle repeats itself. So maybe every 30 minutes or so, you go through this same thing again of strong sense of urgency, maybe incontinence, needing to get to the bathroom quickly. This can happen both day and night. If it's happening at night, obviously it can affect your sleep quite a bit. So we have the small overactive bladder that we see in multiple sclerosis. At the other end of the spectrum, you can have a large underactive bladder. The analogy I use with this issue is it's like you're pouring water into a glass and it's just overflowing. It never empties completely. You can also get bladder spasms or have a sense of urgency and frequency with this, but this bladder is never emptying completely. This is a significant issue because there are two problems with your bladder not emptying completely. That urine sitting in the bladder continuously, never emptying, is a great place for bacteria to grow. So the person with a poorly emptying bladder is at risk for urinary tract infections. The other problem with that poorly emptying bladder is that back pressure is reflected up to your kidneys. So you can actually see kidney damage over time with the poorly emptying bladder. There's a third issue that we can see with the bladder in MS, and it's called bladder dyssynergia. You can see it with either the overactive bladder or the underactive bladder. So what is bladder dyssynergia? Bladder dyssynergia is the bladder squeezing up here saying go, 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 and the valve's not opening down here. So this person says, I know I have to go, and nothing's coming out. So that, maybe after a few minutes, the bladder relaxes. So it's really an incoordination between the bladder muscle squeezing and the valve opening down below. So one of the ways that when we think about managing these different issues, is we have different treatments for these different problems. One of the easiest ways we can help sort out, are you at the small overactive or large underactive end of the bladder issue, is by knowing how much urine is in your bladder after you void. This is called a post-void residual. When I was in training a million years ago, we did this by having the person go to the restroom, and then we put a catheter into the urethra and actually measured how many milliliters of urine were still in the bladder. Luckily, we can be a little kinder nowadays, and we have this device. This is a bladder scan. It's an ultrasound that quickly, painlessly, easily measures how much urine is in your bladder after you void. So with this, we're going to have you go to the restroom. You're going to want to ask the nurse, do we need a sample? Are we looking for a urinary tract infection or not? Maybe we get a sample, maybe we don't. And after you void, you're going to lie down. The nurse is going to use a little bit of gel just under your belly button and actually measure how much is still in the bladder. So what's the magic number when we're looking at this bladder scan? So the magic number that has been developed through different algorithms is 100 milliliters or cc's of urine. So if you're below that, we would say that you have a small overactive bladder. If you're above that, you have a underactive or large bladder. Ideally, it's not going to be subtle. We would like you to if you have an overactive small bladder, we'd like it to be close to 0 milliliters of urine in the bladder. If it's a really large underactive bladder, 200 milliliters, 300 milliliters. Where it gets a little bit tricky is what if it comes back at 110 or 90, is kind of right on the cusp, and that might require some clinical decision making. So if you have a small overactive bladder, we're typically going to look at medications to treat that. The most commonly used class of drugs are the anticholinergic drugs, and there's several of these out there. Things like Detrol, oxybutynin, Toviaz, a lot of different options out there. There's a second class of medications that work through different chemical pathways, and there are two of these. There's Myrbetriq and Gemtesa. So what is the issue with the anticholinergic drugs? The way they work is they work on acetylcholine receptors in your bladder. They tell that overactive bladder, just relax a little bit, fill up more, give me more time. The problem is those same acetylcholine receptors are not present just in your bladder. They're present on your salivary glands and in the GI tract. So you can get dry mouth or constipation with the anticholinergic drugs. There is tremendous variability in how people tolerate these medicines, but usually we're going to start with one of these. Your other class of drugs, your Gemtesa and Myrbetriq, work through different chemical pathways. They tend to not have as high of a risk of dry mouth or constipation. So in a perfect world, we would go directly to one of those medications. Unfortunately, insurance companies are typically not going to let us do that. They're going to want you to go with one of the anticholinergic drugs first. If that works, wonderful. If you have issues with that, side effects, then they'll let you go with one of these medications. So these are your most commonly used medications for a small overactive bladder. What if you're only dealing with bladder symptoms, urinary frequency and urgency at bedtime? There is an old school way of potentially treating that. And that's actually by giving you something that doesn't work on the bladder. It actually works upstream of the kidneys and tells the kidneys to back off on urine production just for a while. So this is DDAVP or desmopressin. It's a naturally occurring hormone that just tells the kidneys to calm down a little bit, only used at bedtime. And again, it may get you through the night without having to get up as frequently. What if your bladder scan says you're at the other end of the spectrum? You have a large underactive bladder. Usually then we want to get a urologist involved at that point. So we don't have as many medication options for dealing with this issue as we do for the small overactive bladder. But we still want to be very proactive in managing this. Remember, we said the underactive large bladder is associated with a risk of UTIs and potential kidney issues if we don't deal with it. So we need to find a way to get that bladder to empty. So this is going to mean typically, if there's enough urine still sitting there, doing intermittent self-catheterization, doing a Foley catheter, a catheter that stays in permanently and is just changed on a monthly basis, or maybe doing a suprapubic catheter. Suprapubic catheter is a small catheter put in just under your belly button, minor surgical procedure, and that's going to help empty the bladder. So again, it's going to be important that we get that bladder empty to help prevent any of those UTI or kidney issues that we've seen. There are some newer kind of treatments out there as well, things that actually, if you will, maybe rewire the bladder. So if I can't get the signal from my brain to the spinal cord to the bladder to tell it to work, what if I just bypass the central nervous system? So there are 2 devices and more in testing right now that basically they're surgically implanted like a sort of almost like a pacemaker on your side. Small electrodes then tap into the sacral nerve roots and send the electrical signal to the bladder to essentially take over what your brain and spinal cord would be typically doing for the bladder. So those are devices that can be looked at. Your urologist who's going to be working with you can tell you about the pros and cons of whether that's going to be a good treatment option for you. There's another electrical option out there, and that's called posterior tibial nerve stimulation. This is a procedure where you would go in to a urologist, maybe a neurologist, and they would actually hook electrodes up to your leg and send an electrical signal that's going to feed back up to the bladder. It's like a training session, if you will, for the bladder. So you do these in sessions, and research has shown that it can help give people better bladder control. One of the other treatment options that I will mention when we're dealing with bladder issues would be Botox or things like Botox. So a urologist can do a cystoscopy. They're going to actually visualize the bladder and do small injections of Botox just to tell that muscle to relax some. Typically, again, used for the overactive bladder or a bladder that's spasming some. When Botox is effective, it's usually going to last you for 3 months or so. What's the downside to Botox? Well, it is a procedure. It's not permanent. Again, it's going to last you about 3 months. Sometimes it works too well. And so if you have too good of a response to Botox, maybe then your bladder's not working at all, and we have to do something temporarily to help it empty, like the intermittent self-catheterization. Mentioning things that work too well, that is a potential risk with our bladder medications that we use for overactive bladder. So we have to be aware when we start one of these medicines, if you go from having to empty your bladder every 30 minutes to not avoiding it at all, say for 24 hours, you need to let somebody know. Either call your healthcare team, go to the emergency room, because that may be a medication that's working too well for you. So those are some of the things we deal with the bladder. What about bowel issues? So again, this can be something that tremendously affects people's quality of life. They may be a little bit, you may be a little bit embarrassed to talk about it, but please do bring it up with your healthcare team. There are treatment options that are out there. So sometimes with the bowel, what we see is people with MS that kind of live this pendulum life where they go from one extreme to the next. They go from having maybe loose, uncontrollable stool to being constipated. With the constipation, a lot of our medications can be associated with constipation. We mentioned the bladder medications that can do that. Baclofen, so many of our different medications can be associated with constipation. So that's something we always want to keep a watch on is make sure we're not causing the constipation with our medications. Sometimes when people have intractable constipation, they will go through this period of overcompensation. They start having loose liquid stool leak around that area of constipation. So that's why people sometimes get this pendulum effect. Our hope is that you stay in the middle of the road, that you're having normal, regular, well-formed bowel movements. There are a lot of different things that we can do to help with that. Hydration is an important one. If you're dealing with bladder issues, sometimes the way that people will try to treat their bladder issue is by restricting their fluid intake. That's bad from a lot of different standpoints. That concentrated urine in your bladder may actually serve as a bladder irritant and actually, paradoxically worsen your bladder symptoms. It also drives constipation. So don't fluid restrict as a way of trying to manage your bladder symptoms. We sometimes use fiber supplements to help people sort of get on a more regular basis. We try to avoid laxatives on a regular basis. They're a little rough on your system. The other thing that we sometimes do is refer people to a pelvic floor physical therapist. If you're having difficulty with fecal incontinence, one of the ways that we might try to manage that is actually by having you work with a physical therapist to try to strengthen those pelvic floor muscles so that you're less likely to have accidents. Whenever we're dealing with bowel symptoms, We want to take a careful history, and if there's anything about your story that just doesn't sound quite right for multiple sclerosis, we want to be pretty liberal with referring you to a gastroenterologist. We never want to assume everything you're dealing with is MS related. You may have another GI issue completely unrelated to your MS, and so we want to sort of keep that in mind and think about referring out to gastroenterology if something just doesn't sound quite right with your story. So there are a lot of different sort of tools in the toolbox for both bowel and bladder. One of the things that I'll also mention is the concept of a bowel and bladder team. So we have this at Shepherd Center. So if maybe you're dealing with both bowel and bladder issues, maybe we've tried a medication for your bladder and we're not getting the results we want, we may sort of call in the cavalry, if you will. So this is going to be a team usually made up of either a physical therapist, occupational therapist, maybe a gastroenterologist, urologist, a lot of these different team members. They will see you as a group and then just come up with a sort of a comprehensive plan to try to manage your individual symptoms. So something to think about if you're having more difficult to treat bowel and bladder symptoms. So in closing, keep bowel and bladder symptoms in mind. Don't be embarrassed to talk about it. We can't help you if you don't talk about it, and there are a lot of different treatment options for managing these symptoms. So one of the other questions that comes up is, again, along the lines of these sort of newer devices. So I mentioned the posterior tibial nerve stimulation, and so that can actually be done either at the posterior tibial nerve in the calf or downstream at the ankle. And again, with this technology, you're going to send that electrical signal back up to the bladder. And in essence, what you're doing is sort of retraining or rehabbing the bladder to sort of get it to do what you want it to do rather than letting it have just a mind of its own and give you frequency, urgency, or accidents. We're doing research here at Shepherd Center with a type of spinal stimulator called Sconex. So again, this is a way of trying to rewire or bypass something that the brain and spinal cord are not doing. So the normal reflex when the bladder fills up is for that signal to be sent via the spinal cord to the brain. Normally what happens then is the brain says, I hear you, I know you'd like to empty right now, but you're not near a bathroom, or you're riding in your car right now, this is not an appropriate time. So the brain will send inhibitory signals back through the spinal cord to the bladder and say, I hear you, wait a little bit, we're going to wait till we get near the bathroom. Depending on where your areas of demyelination are at with your multiple sclerosis, brain or spinal cord, you can affect those normal pathways. So you may not be able to get the signal back, that inhibitory signal from the brain through the spinal cord back down. So in that instance, really your bladder is doing exactly what the spinal cord tells it to do without any inhibitory influence. With other spinal cord lesions, you may not get the signal even to the appropriate places in the spinal cord, so the bladder's just filling up and filling up and filling up with nothing telling it to empty. So again, that's where technology like the bladder scanner are going to help us to sort of tell which of those problems you're dealing with. Some of these electrical devices, including the Sconex in research, are ways of rewiring that and sort of help you reestablish that control over bladder function. So urinary tract infections are in some ways the bane of your existence and the bane of our existence because they really complicate things with multiple sclerosis. If you have a bladder that's not emptying completely, that urine that's sitting there is just a great place for bacteria to grow. Realize that just having bacteria in the urine doesn't mean you have a UTI. That bacteria actually has to bind to the bladder wall. And the reason I bring this up is that some people with a neurogenic bladder have what we call colonization. They have bacteria that are living there in the urine most of the time, but maybe they're not actually causing an infection. So just the presence of the bacteria doesn't mean you have a UTI. They have to bind to the bladder wall. That's when you look at a urinalysis in someone with a urinary tract infection, you're going to see white blood cells. You maybe see blood in the urine. It's not just the bacteria there that constitutes a UTI. So UTIs are problematic in so many different ways for people with MS. For many people with MS, when they have a UTI, their symptoms are not urological, they're neurological. And by that I mean, so your symptom of a UTI might mean worsened walking, worsened cognition. You might not have any burning. You might not have the typical symptoms that most of the public would think of with a UTI, especially for people who've been living with MS for a long time, progressive forms of MS. Maybe you're cruising along, you have a certain level of MS symptoms, and you wake up, you've not had MS relapse for years, and now you wake up one morning and you're having a tremendous difficulty with transfers or walking. If you call in to a call center at your doctor's office, at an MS center, the nurses are trained to ask questions trying to see if there might be a UTI brewing. Again, because that's a common way for UTIs to present. So again, one of our ways of trying to prevent UTIs is we've got to get that bladder emptied, whether it's through catheterization, suprapubic catheters, whatever we have to do. There's some other things that we might do that might lower your risk of UTIs. Remember, we said it, just having the bacteria in the urine doesn't mean it's a UTI. The bacteria has to bind to the bladder wall. That binding is through receptors on the bacteria surface. What if we could just gum up those receptors and not let that bacteria use those? One of the ways that we might do that are through different cranberry products. So cranberry products not only acidify the urine, but they also, some of them actually bind to the bacteria itself. Products like Elura are sort of souped up cranberry extracts that have been shown to actually lower the risk of urinary tract infections. D-mannose is a sugar. It's a pill taken by mouth. You don't actually absorb it. It just goes into the bladder, and it helps gum up those bacteria and might lower your risk of urinary tract infections. So bowel issues in multiple sclerosis, we mentioned this kind of pendulum effect and kind of loose, uncontrollable constipation. Constipation, I mean, they're neither is pleasant, but constipation in some ways we hear more complaints with. When we think about what causes that, the MS itself could be causing it. You may have slower gut motility, just underactive gut motility due to the central nervous system demyelination from your MS. It could be your medications that are doing it, that are contributing to that constipation. Lack of mobility. So it is associated with a higher risk of constipation. We used to have a wonderful nurse practitioner here, Tracy Walker, who specialized in bowel issues, and one of her sayings was, the less you move, meaning the more sedentary you are, the more likely it is that you're going to suffer from constipation. So we want to encourage exercise and movement to help lower your risk of constipation. So when we think about treating constipation, we want to look at those risk factors and take as many of those away as we can. If it's a medication, if it's decreased mobility, if it's a little bit of all of that, we're going to try to manage those things. We do use gastroenterologists in sort of helping work this up. If we see what we think is decreased motility of the gut, we might have you work with a gastroenterologist to help sort that out. Again, we try to limit the true laxatives. We do like using fiber supplements. We like things like Dulcolax suppositories. There's also a sort of a Dulcolax suppository that's souped up or bionic called a Magic Bullet suppository. That is a little bit more effective. It's a prescription form of a suppository. Enemas could be used to help sort of keep you on a more regular basis. One thing we try to do is get your bowel retrained to be more regular. One of the things that you might take advantage of to help stimulate a bowel movement is just a normal reflex called the gastrocolic reflex. Normally when we eat and we put food in our stomach, that sends a signal to the central nervous system to tell your lower bowels to empty. Got to make room for the food coming in from above. Sometimes we take advantage of that, especially if your meal has a lot of protein in it. It can stimulate that gastrocolic reflex. So sometimes people will have a high protein meal first thing in the morning to try to stimulate that bowel movement, and so go in then and sit on the toilet for a while to get that bowel retrained to empty, hopefully empty in the morning so that then you don't have to worry about accidents throughout the day.
So let me start with some questions that people did ask. And by the way, everybody, I'm not going to be saying your name. So if you have a question asked, just ask it. I'll just ask the question. All right. First one is talking about the product called Emcella, I think I'm saying it, a urinary incontinence treatment. And the question is, would this treatment be effective for women and men who have multiple sclerosis?
I'll be honest, I don't have a ton of experience with that particular product. I've heard a couple of people use it. I can't think of any reason why you couldn't use it in both men and women. I mean, there are certain there are certain things in the bladder world that obviously are more male or female specific, like a condom catheter. Obviously, that's not going to work very well for a female, but a lot of the supplements, I mentioned one called Elura during the program, which is a cranberry extract. Those should be pretty gender non-specific.
Okay, thank you. I'm going to take some questions. I'm going to go back and forth, questions online and questions on paper. Person's writing, can I take stool softeners daily?
So stool softeners are absolutely fine to use daily. So one of the prescription versions is Colace. That's actually meant to be used on a daily basis. Miralax, while it's not technically a stool softener, Miralax is okay to use on a pretty regular basis. We get a little bit nervous with the more traditional laxatives, your X-Lax, Correctol type things. We probably don't want to use those on a daily basis, but yes, stool softeners absolutely okay for daily use.
Great, thank you. Another person writes, are suppositories safe to use weekly?
Yes. So I think of suppositories as kind of, if other things have not worked, the suppositories can work really well. So over the counter, you have Dulcolax suppositories. There is a prescription suppository, very appropriately named the Magic Bullet. It is basically Dulcolax on steroids. It works a little bit more effectively. And usually with suppositories, I tell people, I would shoot for no more than about 3 times a week.
When you say these products work effectively, are you speaking about like spontaneous reaction, or is it drawn out?
Yeah, it really varies a lot from person to person. So you raise a great point. When you're trying out one of these things for the first time, like a Magic Bullet suppository, or especially something like an enema, you probably want to be at home near the bathroom and plan accordingly. Maybe stay close to the bathroom that day for a few hours until you see what your individual response is going to be.
Thank you. Does that also apply to like products such as Benefiber?
The fiber supplements usually are pretty gentle. So the fiber supplements are another one of the things that you could do on a daily basis. And normally we think of fiber as something that's going to help you go. We actually can use fiber in some people if they're having loose, watery stools. We can actually use that fiber to kind of bind up some of the fluid in the gut and try to form a more bulked stool and slow things down. One of the problems we see if you're tending towards the looser, more liquidy stools, if on top of that you have weak pelvic floor muscles or a weak valve or sphincter, it's a lot harder for that weak pelvic floor muscle or the valve to work if the poop is liquid. It's a lot easier for the valve or the pelvic floor muscles to work and keep you from having accidents if you have a well-formed stool. And the fiber supplements can sometimes help with that.
Okay, thank you. Getting away from the stool for a moment, a person writes, I just started taking Memory-Cognition for improved bladder control. What do others think are the pros and cons of using this medication?
So again, Merbetrik, and then there's another similar medicine in that class called Gemtesa. This is kind of your second generation bladder medicines. They don't work on the same chemical receptors that our older oxybutynin and Detrols, all those medicines. Those medicines are absolutely fine, but sometimes people can have side effects with the older class. So the side effects that we see with the older medicines are dry mouth, constipation. Sometimes you can see a little bit of confusion. Because Merbetrik and Gemtesa don't work on those same chemical pathways, we usually don't see dry mouth and constipation with those. Merbetrik comes in both a 25 and a 50 milligrams, so we usually start with the 25. Have you tried that for between 4 and 8 weeks? If that doesn't do it, go to the 50. If the 50 isn't working, then we probably need to look at other options.
Okay, thank you. Next, going more to a complementary way of looking at all this, what can you tell us about exercises and how are they helpful for bladder or bowel control, or etc.?
So exercise and physical therapy can be important for both bowel and bladder function. So the pelvic floor muscles, kind of the muscles that sit underneath both the bladder and the rectum, those do play an important role in bowel and bladder function. And if they are weak, and in some people with MS, they can actually be tight. They can be spastic, just like your legs are tight. We can help work with those and improve function through exercise. those are not muscles we normally think of working out. One way of potentially strengthening those muscles is through the good old-fashioned Kegel exercises. You can go online and look up how to do Kegel exercises. Women have sometimes been much more familiar with these than guys have, but guys can do them also. If we really want to give you as good of an exercise program for the pelvic floor as possible, we would have you work with a pelvic floor physical therapist. So there are physical therapists who do this specialized kind of treatment, and they can be invaluable in helping out. In the video, we mentioned just exercise in general. If you are sedentary and you're not moving much, that does tend to affect bowel function, and you will tend to be more on the constipated side. So again, if we can get you moving more, it does help kind of stimulate bowel motility also, and help with bowel movements.
Okay, thank you. Person writes, I wasn't aware of bladder scan. I have all the symptoms of an overactive bladder. However, what is the criteria for getting the bladder scan? And what about the opposite problem, bowel movements before 3 or 10 a.m.? 3 bowel movements before 10 a.m. 3 bowel movements before 10 a.m.
So really, when we're working with people with MS, our criteria and the threshold for getting a bladder scan should be about that much. If you say you have bladder symptoms and we're thinking about managing it, we probably should get a bladder scan. Because it really is the fork in the road. It's the diagnostic test that tells us which pathway you're going to go down in terms of treatment. And it's important that we not guess. If I hear you say you have bladder spasms and occasional accidents, and I think you have a small overactive bladder, when in fact you've really got an underactive bladder that's just kind of spasming sometime, and I put you on one of our medications for an overactive bladder, I can actually send you to the emergency room, because I can inhibit your ability to pee at all, and now you've gone 12 hours without emptying your bladder, and it's just not healthy. So again, our threshold for getting a bladder scan should be super low, and again, something that we use very often in the clinic. On the what was the question again on the bowel function? Give me part 2 again.
So what about, it's written as, what about the opposite problem, 3 bowel movements before 10 a.m.?
Yeah, so if you have too many bowel movements, there's a lot of potential reasons why you might have that. Even though you're having a lot of bowel movements before 10 a.m., is it that you're not fully emptying with each time? So it's kind of like having a bladder that doesn't want to empty well. Are you having a bowel that doesn't empty well? So it's going a little bit and then going a little bit more, and so it's taking you several tries to fully empty the bowel. I think really sitting down and working with, ideally that would be a situation where we probably want to work with a bowel team, where you have maybe a physician and a therapist, either physical or occupational therapy, trying to get a really good history of what's driving that. Are there dietary changes we could look at? Are there medications that you're on that are maybe complicating that bowel picture?
Great, thank you. All right, next person writes, what additionally can someone incorporate into their diet for severe constipation? Fiber at daily recommended levels for intake. You might have mentioned some of this, but this just came up again.
Yeah. So again, foods that are higher in fiber, and you can go online and look those things up. If you have a hard time incorporating those into your diet, then you can certainly use a fiber supplement. I tell people with the fiber supplements, pick the one that is least offensive to you. If you prefer to do a tablet version, there are those. If you prefer to do a liquid version, and then along with foods that might be higher in fiber, you really keep in mind of the staying hydrated. If you are running on the dry side, if you tend to be a little bit dehydrated, that is going to contribute to your constipation. So really an adequate fiber, and then the hydration. We mentioned in the video too that sometimes we try to take advantage of a higher protein meal to stimulate the bowel to move, and so that what you're taking advantage of is the normal gastrocolic reflex, that normal reflex for the bowel to want to empty when you put food in the stomach, especially a higher protein meal.
So the opposite of that, are there any specific foods that people should know about that they should stay away from because it will constipate you?
A lot of that's going to be pretty individual. So in general, if you think of, cheeses, a higher dairy diet, and again, that's very individual. If you tend to be lactose intolerant and you dairy, it may make you have to go to the bathroom and cause abdominal cramping and diarrhea. But we think of, a lot of cheese as being more constipating. Maybe a diet that's higher in breads might be a little bit constipating. It really does vary quite a bit. If you're trying to see which foods you might be better for your diet, one of the ways that you can look at that are things like the Whole30 diet program. Whole30 is basically an elimination diet. You're taking a lot of things out and trying to see how you feel, how your bowel function, how your weight is, and then trying to slowly reintroduce those. You do it for 30 days. I will tell you, it does take a lot of things out of your diet. So alcohol, bread, pastas, most refined sugars, legumes, interestingly, it takes out. But through doing something like that for 30 days, you may be able to identify foods that are unique to you. You can look up Whole30 on the internet. It's basically 4 rules, pretty simple to follow.
Okay, thank you again. Next person writes, why is it concerning when I have a bowel feel the need, does nothing happen? I don't understand. Okay, so why is it concerning when I have bowel? I don't understand this, but evidently when they go to the bathroom, nothing's happening. Also, when I do have a bowel movement, I guess, I never feel like I am done.
Yeah, so those things can go hand in hand. So there's a medical term for feeling like I'm pushing and nothing's happening, so called tenesmus. So in some people, the sensation in the pelvis is actually altered. So you could actually have a sense that you have to go when there's really nothing there. So that's one issue. You could really have poop there that needs to come out, and you just don't have the strength in those pelvic floor muscles and in your abdominal muscles to push it out. And then with that weakness in the pelvic floor and the abdominal muscles, sometimes you're not fully emptying. So the person who was going 3 times before 10 a.m., again, it may be that they're just not completely emptying. If your bowel movement, if your poop is more on that well-formed, kind of softish but not liquid, not hard little rabbit pellets, it's going to be a lot easier for you to push it out. Yeah, so it's the bowel is tricky in MS, and I always feel like we sometimes have these very clear algorithms for bladder symptoms, and with the bowel, it's not quite that clear. Sometimes there's a lot of trial and error that goes on in terms of getting someone's bowel function right.
Okay, thank you. Okay, I hope everybody knows that not all of these questions are mine, and I am just reading from the boards. Okay, and when I say I, it's not I, it's whoever I'm reading's I, and not that I either. Okay, I use adult diapers at night and still have problems peeing at night, sometimes in my sleep. I think my urologist said I have a flaccid bladder. What would you advise?
So if you have that, so when we say flaccid bladder, sometimes people use the term neurogenic bladder. That's the big bladder that doesn't want to empty. So the urine is just sitting in there, but it overflows, and that person has very little control over when they go. So the part of that is we want to make sure the person is emptying, and so intermittent self-catheterization, suprapubic catheters, those things may play a role in the person who really has the bladder that's not emptying. At bedtime, it can be frustrating for people because if the bladder spasms or they have an accident, then that interrupts their sleep, then they can't get back to sleep. That might be the person that we talk to about the DDAVP or the desmopressin. That's again that old naturally occurring hormone. It doesn't work on the bladder, it works on the kidneys, and it just tells the kidneys to back off on urine production just for bedtime. You don't want to use that as a daytime medicine, again, only for bedtime use.
Okay, thank you. And for those with an overactive bladder, where you're talking about right now, a person writes that he or she gets Botox now, but they also want to see what else might be out there that's similar or better.
So there are competitors to Botox out there. I don't know that one is necessarily better than the other. Sometimes it's the urologist's individual preference as to which one they're using, or insurance may dictate, which of the Botox type products you're going to use. So again, what Botox is going to do, for those who are not familiar, you're going to do a cystoscopy. You're going to put a little catheter up into the bladder, and the urologist is going to do these selective injections to different parts of the bladder to tell it to relax, to treat that overactive bladder. If someone is not getting the response they want with Botox, we mentioned in the video these posterior tibial nerve stimulation sessions where you go into a urologist and they're trying to help you retrain the bladder through this electrical stimulus sent through the nerve in the leg up into the bladder, or the research that's being done on the Sconex device that we mentioned. So that's similar to posterior tibial nerve stimulation, but with this one, the Sconex, the electrodes are actually placed over the back, so it's more of a direct spinal stimulation.
Okay, next, what are the best management controls that you have for urine accidents, or that you know about?
So again, it's, when the person says they're having accidents, we need to back up and say, why? What is your bladder doing? Is it small overactive, large underactive? And if it's the large underactive, are you having bladder spasms? Because again, the treatment algorithm, the path that you go down is going to be very dependent upon which of those you're dealing with.
All right. Next one writes, along with good hygiene habits, what's the best and most natural way to prevent UTIs? I've tried several medications without success, and I really don't want to put any more pharmaceuticals in me than I have to.
So again, if the UTIs are being driven by urine always sitting in the bladder, if that person's not emptying, again, first we find it with the bladder scan, then we treat it. Again, don't have as many medications for treating that, underactive bladder. There are some things that are tried in both men and women to hopefully improve the outflow of urine so that you do empty better. So the medicines that guys use for prostatic hypertrophy can be used in both men and women with MS to hopefully help that outflow of urine. If it's a significant outflow problem, if we're not emptying, that's again where we're going to start thinking about things like intermittent self-catheterization, the suprapubic catheters, because we've got to get that urine out of there. And I think we mentioned in the video that the other problem, other than UTIs, that we see with the bladder that doesn't empty, is that back pressure of the urine sitting in the bladder all the time is reflected up the ureters, the tubes to the kidneys, and you can actually see some kidney damage over years of the bladder not emptying well. The two things we mentioned in the video that kind of prevent bacteria from binding to the bladder wall, I'm big believers in these. So these do potentially lower the risk of UTIs. There are lots of these cranberry products out there. I mentioned the one that we use the most, Elura, it's ELLURA. There are others out there that again, these are cranberry products that bind to the bacteria in the urine, and they just don't let the bacteria do anything. They don't kill it, they just don't let it give you an infection. Or D-mannose is the other product that can be taken by mouth. That's a sugar that binds to the bacteria and doesn't let them cause a UTI. I think of the cranberry products and D-mannose as being pretty natural. I mean, they're really not absorbed to any degree in your bloodstream. So it's, if you're trying to avoid prescription medicines, those are some more natural ways of preventing UTIs.
Okay, thank you. Next question is, what other forms of bacteria can cause UTIs?
So, I mean, the list is pretty long. I mean, E. coli is probably the big bad actor that we see a lot of. Pseudomonas species, and then they just go from there. So when we do, a urine sample, if you have X number of white blood cells or X number of bacteria in the urine, that's going to trigger the lab to automatically send that urine sample off for a culture. That's where we can sort out, specifically what bacteria is in there and look at the sensitivities. So the sensitivity is what antibiotics is it going to respond to. One of very frustrating things, we'll see happen every now and then is, let's say you give a urine sample and the doctor's office calls you back and says it was a dirty catch. What that means is we didn't get a clean sample. And so we've got skin bacteria showing up in the urine sample. One of the ways that we know that it's a potentially contaminated sample is if we see a lot of skin cells or epithelial cells in that urine sample, that largely makes that urine sample not usable. So it's really important that we try to get as clean of a catch as possible so that we can specifically identify the offensive bacteria.
Okay. Next, what is the normal amount of bathroom trips for an average individual, and how is it affected by liquid and fiber consumption?
So, again, lots of individual variability. So I would start with bowel movements. I think ideally you'd see a bowel movement once a day, but there are people who are, within the range of normal who are going every other day. Where I start getting nervous with bowel movements is a person who's going, once a week or so. That's just, that probably is going to get uncomfortable at some point. With urination, again, it varies quite a bit, from person to person. Ideally, we'd like to see people going to empty their bladder about every 4 to 6 hours or so. Maybe a little less. We'd love for you to get through the night completely, but during waking hours, somewhere about every 4 to 6 hours. You can impress your friends and neighbors over the holidays. Tell them that you learned tonight the difference between urination and micturition. So we use the term urination for when we pee. That's technically not correct. Medically, urination describes the process of the urine going from the kidney to your bladder. Once it leaves your body, that's technically micturition. So you can throw that out at the dinner table.
Okay, great. Sounds like a great. I don't know what you call them, but trivia game. Trivia, it's from trivia, right? All right. So let's talk about aging with MS and having bladder issues. So is it the aging? Is it the bladder? Is it the MS? And how is it treated differently for one way or the other?
Yeah. So both men and women can have bladder issues that are unrelated to their MS. Some guys, as guys get older, you can see enlargement of the prostate. So that the tube to empty the bladder unfortunately goes through the prostate. And guys, as we get older, sometimes the prostate enlarges. It pushes on that tube, so your bladder doesn't want to empty very well. The urologist can help sort that out. Again, we mentioned this medicine, tamsulosin. It can be used whether it's an MS outflow problem or a prostate outflow problem. In women, especially women who have had kids, there can be this what we call stress incontinence. So the bladder can be damaged a little bit just through the pregnancy and childbirth process. So these are women that will report urinary leakage with coughing, sneezing, jogging, anything that sort of jars the bladder. Women can get mechanical problems, prolapse or sort of a falling, if you will, of the bladder. So it's not sitting where it should be. These are all things that a urologist should be able to help sort out. And there may be slightly different treatment pathways for some of those things. For instance, in a woman who has a mechanical issue, that may end up being a surgical problem just to kind of help support and keep the bladder where it should be.
All right, that brings up, you're like sliding right into the next question. What helps if you feel like you're going to have an accident with your bowels or bladder each time you cough, sneeze, or laugh?
Yeah, so in a woman, that's going to be pelvic floor weakness, and that may be more than MS. That may be childbirth related. Again, that's where that kind of falls into both the urologist and the gynecologist realm. So either one of those specialists can help with women who are experiencing that. With a guy, it'd be obviously, guys are not having childbirth, so it's not that mechanical stressor. If you have an overactive bladder, a small overactive bladder, normally it contracts on its own. You don't have to do anything. But I have seen some people actually have what sounds like stress incontinence, with guys included, cough or sneeze due to a neurologic small overactive bladder.
Okay, thank you. Next, for people that do catheters each day but have terrible trouble with their bowels, A person here takes Movicol every night and 2 suppositories every morning and suffers from Anni syndrome. It's very painful. Is there anything you can do? And is there anything that you know that this person can do? And is this an MS thing or other?
So it's hard to know just based upon the symptoms, whether it's all MS or it's a combination of things. And I don't want to give the person bad advice. That's really going to be something a gastroenterologist is going to have to tease those issues out. Is it all MS? Is it all something else? One of the things that we mentioned in the video that we think of for both refractory bowel and bladder issues is what if we could rewire the bowel. So this InterStim device, and then there's a competing company, Axionics. So these are surgically implanted devices that rewire either the bowel or the bladder. We traditionally only thought of them as bladder, sort of treatments, but they can be used for tough bowel issues, like this person is describing. So it's a big commitment for someone to have a surgical procedure, have a device implanted in their body. So there are trials that can be done where there are temporary devices to see if it actually does what you want it to do. So that would be something that this person may want to talk to their gastroenterologist about to see would they be a candidate for something like that.
Okay, thank you. Next, where does Vesicare drug fit into the bladder control thing? Is there any problem using for 12? I don't know what that means.
Maybe 12 years or
12 years, yes.
So Vesicare is in that class of older drugs, the anticholinergic drugs. So before we had Myrbetriq and Gemtesa, what you saw with the anticholinergic drugs is that with each generation, and Vesicare is one of the newer generation anticholinergics, they were trying to get rid of some of the side effects, get rid of the constipation, get rid of the dry mouth. So Vesicare fits in that camp. There is no expiration date on how long you can use Vesicare for. If it works for you, it works for you. There's not a time limit on how long you could use that.
Thank you. And next one says, a person was making a comment about something I believe you mentioned earlier about Elerol, that it's a cranberry sold in stores.
Correct. Elura is sold in stores. You can just Google it. Also, they have it on Amazon. My only probably complaint with it is it's a little bit on the pricey side. So if you look at some of the simple cranberry extracts that you could pick up at the drugstore or at the grocery store, this one's going to be a little pricier. I want to say it's up in the $55 a month range in that ballpark. But when it works and it keeps people from having UTIs, it's not going to prevent every UTI, but it does seem to lower the risk for a lot of individuals.
So again, many people hear that they should always drink cranberry juice, like what you're even talking about now. But is there any other juice that they could also drink in case they don't like cranberry juice?
Yeah, not that that would have that sort of protective effect, with the bladder. Not that I'm aware of.
Okay.
That's where if someone just doesn't like the taste of cranberry juice, that's probably where doing one of the pills, the supplements, so you can just pop a pill and you're done for the day.
Okay, thank you. We have 4 questions left. All right, next, is trospium, I know I screwed that one up, effective for small OAB? And if so, how much is appropriate?
Yeah, I would say that's something that the urologist, it'd be very rare that you would probably see a neurologist, an MS specialist, prescribing that. That's usually going to be something that if you failed all of the other standard, the anticholinergics, your Myrbetriq, your Gemtesas, that someone's going to look at that. So and the dosing, again, is going to be very individual. With some of these drugs, what you're going to do is you're going to go up on the dose until either you start having the desired effect, you're treating the overactive bladder symptoms, or you start bumping into side effects. So again, pretty individual on that.
Okay, thank you. Before I get down to my last 3, if anybody else out there has something to ask, now's the time to type it, because we're not going to be here in another 10 minutes if you don't type it. Okay, next person writes, heard of Dr. Mercola's By the way, I had an eye exam today, so it's very hard to see with dilated eyes, right?
I bet.
Heard of Dr. Mercola's D-mannose? Is that what you're talking about earlier? D-M-A-N-N-O-S-E. Any thoughts? And I think you already spoke about that, but if you could say it again, please.
Yeah, so D-mannose, it does kind of the goal with D-mannose is very similar to the goal with the cranberry products. Is again that you're just having bacteria sitting in your urine doesn't mean you have a UTI. That bacteria has to bind to the bladder wall, and think of it like kind of like Velcro. There's you've got Velcro on the bacteria, Velcro on the bladder wall. They stick together. That starts the infection process. So if we can gum up the Velcro on the bacteria with either a cranberry product or D-mannose, that's the way that those products work. So yeah, D-mannose is, if you're having frequent UTIs, is certainly something to keep in mind.
Okay, thank you. And again, for everybody that's got a question and afraid to ask a question, trust me, I am not going to remember it in 10 minutes from now. All right. I've got a desktop full of things to do, and there is no way I'm going to remember your question. I don't even remember what was asked earlier tonight or even 5 minutes ago. All right, next, a new person writes, is there any way to control the timing of my bowel movements? I don't drink enough water. I'm in a diaper all day and in a power chair all day, and live alone and have help in the morning and at night. My gastro PA, not an MS guy, wants me to take Citracel to make me more regular, and it scares me.
So this kind of falls into the camp of bowel training. You're trying to get your bowel to go when you want it to go, when it's convenient for when you have help in the home, when you have caregivers, and so it is a process. And so a lot of times what it involves doing is trying to sit on the toilet or trying to have a bowel movement at a certain time of day, even if it means sitting there and trying for 30 minutes or so, taking advantage of that high protein meal first thing in the day, so that you can try to stimulate that bowel movement. This is where your bowel and bladder team, that team of therapists and healthcare providers who work with bowel and bladder issues, can be of benefit. Sometimes with the bowel, we hit a point where we are just not getting where we need to be. Someone either has intractable constipation, they're having accidents all the time, and if you have bowel accidents, you run into hygiene issues, you can get skin breakdown. There are a whole host of problems. You can have a higher risk of UTIs, especially in women. I know it sounds radical, but in some of these more extreme situations, there are people who will look at things like colostomies just to give them control of their life. It's not common, but we do have a handful of individuals with MS who have had a colostomy because the bowel symptoms were that severe. And most of them, as aggressive as that sounds, have a much better quality of life. These are individuals who say, now I'm back in control. I'm not living, worrying about having accidents and worrying about the hygiene issues. It can be an option for some people.
Thank you. All right, next. Oh, see, people are waking up.
There you go.
There you go. So let me get to some of the older ones first, if they weren't repetitive. Is having only 1 or 2 bowel movements per week a bad thing?
Again, and I hate that I sound like a broken record with the individual nature of this. For some people, I would say 1 a week. I'd like to see people maybe have a little bit more than that. 2 a week is not extremely abnormal for some people, and some of it comes down to how comfortable are you. When you have a bowel movement, are you really having to strain, and are you having this large volume bowel movement, so that maybe having smaller, more frequent bowel movements might be ideal. So it's going to be very individual.
Okay, thank you. Let's go with this. There's a multiple part question about Elora. One, is it better than Azo, Target, or other cranberry concentrates? Is it more expensive? Elora is much more expensive. Can one get a prescription for Elora? And is Elora different composition than cheaper cranberry pills? This person says that they are just trying to understand all of this.
Yeah. So no offense to the Azo type products. I do think the products like Elora are more effective. They are more it's just a more concentrated, more potent, cranberry extract. They are also more expensive than the products like Azo. You do not need a prescription. Again, you can just Google that word, Elura, and you'll find it. I'm 99% sure Amazon has it. It's hard to find in a drugstore. So, like our apothecary here at Shepherd Center, because we work with people with MS and spinal cord injuries, a lot of bladder issues, we order it and we always keep it in stock. But I don't know that I've ever seen it at Walgreens or CVS or Target. So you usually going to get it online from somewhere. If you're having frequent UTIs, think about what that does to your MS. Your neurological symptoms worsen every time you have a UTI, or people are having to go to the emergency room, or maybe even get admitted to the hospital. If we could knock that frequency down, to me, that the higher price of the Elura is worth it.
Great, thank you. Before I go on to the next questions, I want to let everybody know this program is or has been video recorded. And this portion of the Q&A is also being video recorded so that we can play this all put together as the dialogue and then the Q&A all together on one recording, and that will be on our YouTube channel. It will not be for at least 5 to 10 days. I've got 40 other videos in front of yours to get published before the end of the year. And so that's where it stands right now. All right, again, this is our 107th program of the year, and there are still many to be looked at and get online, and that's where it sits right now, okay? But it will be done before the end of the year. All right, next question is a person writes that their family doctor recommended seeing a urogynecologist. So what can you tell us the benefit of a urogynecologist over a urologist?
So urologists obviously treat both men and women, where the urogynecologist is going to treat only women. I think when you add that gynecologic piece, if there's any suspicion that there's some type of mechanical non-MS related issue, or if there's thought to be, say, thinning of the vaginal tissue, something that might have a hormonal component, I think that's where a urogynecologist is going to be able to help that person out a little bit more. So there are subtle differences between those two.
Right, thanks. And can probiotics help stabilize bowel movements or movements due to food sensitivity?
So we all want to have a normal, healthy, gut flora or gut biome. So that's the bacteria living in our gut. We know that the bacteria living in the gut of a person with MS tend to look different than the non-MS population. We think that has a role in the immune system, but it probably has a role in the gut also. I mean, in the bowel movements and just daily bowel functioning. So for most people, if you have a reasonably healthy diet, I don't know that everyone needs to take a probiotic supplement, but if you have concerns, if your diet's not great, if you are on antibiotics periodically, so let's say you have UTIs and we're giving you antibiotics, well, we know those antibiotics can really, wipe out your gut biome. So in those situations, maybe taking a probiotic supplement is a good deal. Again, lots of individual variability. I've seen people start probiotics and say, ooh, for a little bit, it actually, it may be bloated or it may be worsen my bowel function. So there may be a sort of a learning curve for your gut as you get used to that probiotic supplement.
Great, thank you for that. And before I get to the last two questions, I believe, I just want to let everybody know I started the year in a tie. I'm ending the year in a jersey. The weather's changed, right? And yeah. Tomorrow night is the last program that I'll be on as well, although we do have another program next week with our clinical social worker, and she will be doing depression in times of the holidays and helping people get past that. Tomorrow night's program is based on simply and only MS symptom management. So if you want to join us for that, get onto our website, get registered if you're not already for that program, and be there or be square, right? I love saying that. Okay, so next, so of course, more questions. Here we go. All right, first one is thoughts on, I'm going to screw this up too, kombucha to help with bowels.
Yeah, so kombucha is kind of this, fermented beverage that has some probiotics in it. I'm absolutely fine with it. If you want to see if it helps with bowel movements, yeah, I certainly wouldn't discourage someone from trying it. Some people don't care for the taste. There are different versions of it out there. But yeah, it's certainly worth a try.
Okay, thank you. Next one, more about the urine from the coughs and sneezes, but a person writes that he or she coughs, sneezes like constantly all the time, and they always lose urine and do not have time to get to the bathroom. Is there any way to cut down on those sneezes or coughs? And wow.
Sounds like we need to see an allergist to cut down on the coughs or
Well,
sneezes.
that's what I was going to say.
Yeah.
That's exactly what I was going to say.
I mean, short of that, I mean, obviously we'd love for you not to cough or sneeze so much. So I would ask your primary care doctor, why am I coughing and sneezing so much, and see if we can address it at the top end by cutting back on that. And while you're working on that, sort of still look at the bladder end. Again, this may be a situation where there's some stress incontinence, non-MS related bladder issue on top of a small overactive bladder. So this may be a team approach between the neurologist, the urologist, and the primary care doctor, trying to hit it from every angle.
Okay, thank you. So next one is a person asking, what were the names of the newer bladder meds? I'm on oxybutynin, and the dry mouth is causing teeth issues.
Yeah. So oxybutynin is the granddaddy of all, the bladder medicines. So that was one of our original ones. Oxybutynin works, but by the time you get to a dose where it works, a lot of people are having some pretty unacceptable dry mouth. And as this person mentions, one of your major protectors of your teeth and it cuts down on cavities is your saliva. We have antibodies in our saliva that helps kill bacteria. If your mouth is dry all the time, it's actually not good for your teeth. So the options in this case would be to move to a newer anticholinergic, something like the Vesicare that the person mentioned earlier, or Detrol LA, that have a lower risk of the dry mouth, or move away from that class altogether and get to one of the two newer drugs. Again, the newer drugs are the Myrbetriq, Myrbettriq, or Gemtesa, Gemtesa. Between the two, Myrbetriq and Gemtesa, I'm happy if insurance will cover either one of them. I've not seen big differences in the effectiveness between those two.
Okay, thank you. So there are no more questions, and there are several, though, that are giving their kudos to your presentation, to the questions asked, the way the questions were asked, and so on. So I just want to thank everybody that was online tonight. We had a very nice assembly of people here, and I'm glad for that. And again, I want to thank everybody for being online. I want to thank you, Dr. Thrower, for the many programs that you did with us this year, and the many more that we're looking forward to doing with you as we go forward. Okay. Good night, everybody.
Thank you.
And happy holidays.